I'm very excited to welcome our next presenter, Dr. Sharon C., who we're so happy to have joining us again for this session. Dr. C. completed her undergraduate and medical education through the Brown University program in liberal medical education in SUNY Stony Brook. She trained in neurology at Mount Sinai, where she also served as chief resident and went on to fellowship training in electromyography at New York Cornell Presbyterian. Dr. C. began her career at Maimonides Hospital and today is professor of neurology at the Mount Sinai Movement Disorders Center, where she specializes in Parkinson's disease, tremors, dystonia, and other complex movement disorders. Dr. C. is a diplomate of both the American Board of Psychiatry and Neurology and the American Academy of Electrodiagnostic Medicine. Dr. C., thank you so much for joining us this morning.
Oh, thank you so much for inviting me to give this talk on movement disorders. My name is Winona C. I'm at the Movement Disorder Center at Mount Sinai, and today we're going to talk primarily. Let's look at our. Okay, so today we're going to talk primarily about Parkinson's disease. I would say that Parkinson's disease and Parkinsonism make up the bulk of our practice here in the Movement Center at Mount Sinai. So we will spend most of our time talking about Parkinson's disease, atypical Parkinsonism. If we have time, we'll talk about some other movement disorders, essential tremor and restless legs. Oops. So have no financial disclosures. That's what this is. Okay, so in 1817, this is actually a statue of Alexander von Humboldt. He was a German philosopher, but I think it's a nice depiction of the typical stooped posture, which is one of the main features that you'll see in people with Parkinson's. So actually, Parkinson's disease was first fully described by James Parkinson. He was an internal medicine doctor, actually. And in 1817, he wrote the essay on shaking palsy, and it was a very nice description of the typical core features of Parkinsonism. So when we say Parkinsonism, it really refers to an umbrella term in which there are many conditions that can cause a picture of Parkinsonism. The most common is idiopathic Parkinson's disease, and today we're going to talk about Parkinson's disease and all the other atypical forms of Parkinsonism that fall under this Parkinsonism umbrella. But when we say Parkinsonism, we mean that the patient has a constellation of features that include a combination of tremor at rest, rigidity, typically what we call a cogwheel rigidity that can be most easily elicitable at the wrist, but can also be elicited at the elbow. There is bradykinesia, referring to slowness in movement, but also it refers to a slowness in initiation of movement. So many patients will have difficulty initially getting started with movement, but once they start the movement, they often can keep going. And a somewhat later feature is postural instability or loss of postural reflexes. So the most common cause, as we mentioned, of Parkinsonism is idiopathic Parkinson's disease. And when we say Parkinson's disease, we mean pathologically, the typical characteristic is that there is a progressive loss of dopamine-producing neurons in the midbrain in the substantia nigra. The remaining neurons contain these abnormal cellular inclusions that are called Lewy bodies, and they contain alpha-synuclein, or what we call abnormally aggregated and misfolded alpha-synuclein protein. So here you can see a pathology slide of the midbrain, the substantia nigra pars compacta, and actually at the point at which here you can see a characteristic pallor of the substantia nigra, which is what you see in people with Parkinson's. What's interesting is also that by the point at which patients come in with a tremor, it's thought they've already lost about 50 to 70% of the dopamine-producing neurons in the substantia nigra. So now there is also a push in terms of trying to identify biomarkers that may predict the onset of Parkinson's disease. The typical pre-motor manifestations include things like impairment in sense of smell, which is hyposmia or anosmia, constipation, and a sleep disorder called REM behavior disorder. REM phase sleep is the phase of sleep in which you are dreaming and your body is actually is basically flaccid and paralyzed in a sense. Instead, these patients during REM phase sleep have paradoxical movements, and so they appear to be acting out their dreams. We now know that the presence of REM behavior disorder can precede Parkinson's by many years, and if a patient has REM behavior disorder, it's highly predictive that the patient will go on to develop what we call synuclein diseases, which includes not just Parkinson's, but also Lewy body disease and multisystem atrophy, which we're going to discuss. So here is a depiction of what the typical Lewy body looks like. Okay, so as we said, Parkinson's, in my view anyway, still remains a clinical diagnosis. However, we're going to talk a little bit about some new advances that have occurred in the diagnosis of Parkinson's that have helped us to further confirm this condition. And actually, these advances only came about approximately 5 years ago or less. So we're going to talk about some imaging and other biopsy tests that we can do to further confirm a diagnosis of Parkinsonism. So the patient has to have a combination of the tremor at rest, meaning that the limb is fully supported and there's a tremor, meaning a rhythmic movement, typically 3 to 5 hertz tremor, which is occurring typically in the hand. It could also start in the leg as well. And usually with Parkinson's, the onset of symptoms and signs is unilateral. So a very typical presentation is a rest tremor in an arm and leg or rigidity in an arm or leg. But over time, the signs will progress to affect the other side. But even in very advanced stages, the condition remains a somewhat asymmetric illness in that one side of the body is typically more affected than the other. There is the presence of cogwheel rigidity in the affected limbs and the slowness of movement, bradykinesia. And then I say that postural instability is a later feature because it typically is not an extremely prominent feature at the very beginning of the illness. However, if a patient has very severe postural instability at the very beginning of illness, it would make us think about other forms of atypical Parkinsonism. The most classic is progressive supranuclear palsy that we're going to discuss later. So we also know that there are many motor and non-motor features in Parkinson's. Other motor features that one can see are freezing of gait. You can also see abnormal contractions of muscles producing abnormal sustained or twisting postures called dystonia, typically focal dystonia. For example, the patients may say their toes curl or the foot turns inward, which can either be a symptom of the disease or can be a side effect as well of the L-DOPA, the levodopa that we treat patients with when they develop what we call dystonic dyskinesia. Festination is also another unusual gait disorder, which unfortunately is medication refractory for the most part, but it is a tendency to adopt a running pace. In addition to these motor features, we now know there are so many non-motor features that affect our patients. So the autonomic nervous system there are many autonomic features in Parkinson's. The most common is orthostatic hypotension, but patients typically also have urinary issues such as urgency, frequency, and in later stages, even incontinence. And constipation is a pretty almost universal, I would say, symptom of Parkinson's. And some people hypothesize that because it's a premotor finding in Parkinson's, that perhaps it has something to do with the pathophysiology of Parkinson's. It's been shown that even in early stages, patients have deposition of Lewy body in the gut. And so one theory is that perhaps the pathologic mechanisms of Parkinson's have already started in the gut and travel through the vagus nerve into the brain. So that's one theory. There's also a cognitive dysfunction that can occur typically in later stages of Parkinson's, as well as neuropsychiatric features such as depression and anxiety. Okay, so this is a very busy slide, but I just wanted to show you a typical face of a patient with mild Parkinson's. So we rate the facial expression, and patients do get a facial bradykinesia as a result. A very mildly affected faces would be called is like considered like a mild staring facey, or actually in our rating scale, we say it could be a normal poker face. As the face becomes more rigid and bradykinetic, the mouth will tend to stay somewhat open spontaneously. And here we're just talking about the bradykinesia and the rigidity. Interestingly, although only about 70% of patients present with a tremor at rest, that means about 30% of patients only present primarily with rigidity and tremor. Patients really only need to have two of those three main cardinal features, or 2 out of the 4, including postural instability, to make a diagnosis. Okay, but some patients only present with what we would call an akinetic rigid presentation, where they never have tremor. Interestingly, though, presence of rest tremor often is not disabling, except perhaps in a social context, if the patient has primarily a pure rest tremor. Now, patients can also have a tremor holding a posture. We call that postural tremor. Or when we test them with finger to nose, they may have a tremor as they approach the target with their finger, and we would call that an action tremor. So patients can have a combination of rest tremor, postural tremor, and action tremor. The rest tremor in and of itself doesn't tend to disable people in doing their activities, but what most patients would report is more disabling is the bradykinesia, the slowness, and the rigidity. And over time, the postural instability will lead to imbalance, and the most advanced stage, the patient may even fall while just standing. Okay, so we talked about that the classic findings of idiopathic Parkinson's includes unilateral onset of symptoms, presence of rest tremor. We also, when we examine the patient and we do the rest of the neurologic exam, we're looking for other features that would not be expected. We should not expect presence of upper motor neuron signs such as spasticity or upgoing toes, a Babinski sign. These, what we call cortical spinal tract findings, can be seen in other atypical Parkinsonism, typically multiple system atrophy. Okay, so that would give us a clue that the patient may not have typical Parkinson's. Also, the history of idiopathic Parkinson's is that in general, it is a slowly progressive neurodegenerative condition. So generally, we can reassure patients that the progression is typically slow. The other aspect is that the levodopa works very well for the most part to control pretty much all the symptoms of Parkinson's disease. So we say that the response to levodopa should be dramatic. Occasionally, we do have some patients that do have Parkinson's disease. They have a lot of rest tremor, but unfortunately do not respond to, let's say, high doses of levodopa, and they may have medication refractory tremor. They still have Parkinson's disease. So the levodopa response for tremor may be a little bit less uniform than the response to bradykinesia and rigidity, which I would say is more uniformly responsive to the medication. Okay, so we're going to talk about here. I wanted to mention one of the advances in Parkinson's disease research and clinical care is that we know that a lot of genetic mutations may underlie Parkinson's disease. I would say that when we see patients in the clinic, for the most part, most patients do say that they don't have family history. However, it could be that patients are maybe unaware whether or not there is someone in the family that may have it. Also, many patients do not get genetically tested just because of access to genetic testing is not uniform at this point. So these are some of the mutations that we will test. We have a genetics counselor. And if we think the patient may have a genetic mutation underlying Parkinson's, even though at this point it's still a small minority of patients, we will test for that. However, these genetic mutations are a big area of research in Parkinson's. For example, LRRK2 mutation is the most common form of autosomal dominant Parkinson's disease. And knowing about the mutation may help to, in the future, perhaps to target therapy, sort of like precision medicine that we already have for oncologic care, and that may be the case in the future for Parkinson's. And in fact, many drugs, as you can see here in the targeted therapy, are being developed for these underlying gene mutations. Another area of research has been the GBA mutation. Patients with homozygous mutation of the GBA gene, the glucocerebrosidase mutation, actually, if they have a homozygous mutation, they have Gaucher's disease. However, patients who have a heterozygous mutation of GBA do not have Gaucher's disease, but they have a high risk of developing Parkinson's. So there's a lot of research being done on GBA-related mutations, and it's a good example of a gene mutation where therapies are very targeted towards the enzymatic pathway. GBA is involved in impaired lysosomal degradation of byproducts and is also linked to alpha-synuclein as well. So it's a very interesting molecular pathway in terms of studying of effects on Parkinson's. So I wanted to mention briefly, probably about 5 or 6 years ago, DAT scan was developed. DAT scan is similar to a PET scan. The patients are injected with a radioactive tracer, and it is actually being taken up by the dopamine transporter in the brain. In Parkinson's disease, the dopamine transporter is abnormal, is deficient. So they will have deficient uptake of the radioactive tracer in the basal ganglia, specifically the putamen. So here, on the right, you see the normal scan. They say it looks like a comma. And the tail of the comma is the putamen. And so this normal scan is a patient with essential tremor. And then the scan, which is abnormal, shows that there's loss of the comma. So there's deficient uptake of the radioactive tracer in the putamen. And this is actually a patient with some sort of Parkinsonism. Now, the DAT scan does not diagnose Parkinson's disease per se. It diagnoses an abnormality in the presynaptic dopaminergic pathway, so a presynaptic dopaminergic deficit. So what is an example of presynaptic dopaminergic deficit? That would include Parkinson's disease, other forms of Parkinsonism, such as multiple system atrophy, could be abnormal in patients with Lewy body disease, a cortical basal degeneration, or PSP. It should be normal in patients that, for example, have a postsynaptic dopaminergic pathway abnormality, such as drug-induced Parkinsonism. Drug-induced Parkinsonism is generally caused by antipsychotics, and it's because there is a postsynaptic dopamine receptor blockade by the antipsychotic. So theoretically, it should be normal in that situation, so it may be useful to differentiate a patient who, for example, might be on Haldol and you're not sure if they have drug-induced Parkinsonism or do they have underlying Parkinsonism. A better way would be to get them off the antipsychotic completely, but oftentimes that may be difficult to do. However, the caveats are that it is not 100% diagnostic, so theoretically one could still have false positives and false negatives. And even newer test that has been developed has been the skin biopsy, and we've been doing that in our clinic. Skin biopsy is predicated on the fact that we see the misfolded alpha-synuclein in the skin of patients with Parkinson's. So here it's showing you that we take a little punch biopsy from 3 different areas of the skin, 3 different areas of the body, and it's sent to this lab, SYN1, and they look for the presence of the abnormal alpha-synuclein in the skin. So the reason it's taken from proximal areas and distal areas in the body is they are looking to see whether or not they can differentiate different forms of Parkinsonism based on the distribution of alpha-synuclein. That is still being studied, but it has been helpful because the results will come back and will say abnormal alpha-synuclein, and that may help support your diagnosis of Parkinson's. Okay, just mentioning very briefly that in old age, elderly Parkinsonism tends to present primarily with an akinetic rigid syndrome, and in younger people, more of a tremor predominant presentation. But of course, older people can also present with tremor as well. And many times patients often ask me, how do you know it's Parkinson's? I mean, could it just be normal aging? Well, I guess I would have to say that we have to use our judgment in terms of, do we think that the level of slowing of movement is out of proportion to the patient's age? Also, the presence of tremor is very helpful. that should not be considered part of normal aging. Dementia is more common in the older onset PD, and our older patients with dementia with Parkinson's are very vulnerable to develop side effects of treatment, mainly neuropsychiatric side effects such as hallucinations, which can occur with the levodopa medications. Okay, so now we're going to talk about, the atypical Parkinsonism syndromes. Okay, so PSP. PSP is probably, I think, the most common atypical Parkinsonism, although overall they're all kind of rare. So the hallmark of progressive supranuclear palsy is in the name, supranuclear palsy. That means above the nucleus, gaze abnormality palsy. So classically, these patients have a impairment or paresis of initiating vertical eye movement, saccades. So eventually the vertical gaze will become completely paretic, and the patient cannot initiate vertical saccade up or down. Typically that in the beginning, you'll see it's out of proportion to the lateral eye movements. Lateral eye movements can be relatively normal early on. The other thing that is confusing about this condition is that the patients may present with Parkinsonism initially, but they don't have the supranuclear gaze palsy very early in the illness. However, they may have subtle findings such as loss of optokinetic nystagmus vertically, that, if you tested nystagmus, then you for OKNs, then you might see that, but it may be pretty subtle. But as time goes on, eventually every patient will develop the vertical gaze palsy. So the most common presentation here, as opposed to typical Parkinson's, is that the patients will present with early falls and early balance impairment. And that is pretty unusual for regular Parkinson's. The patients will say that they've had a year of symptoms, and it initially started with a progressive gait disorder and falls and gait impairment. So one should be suspicious if a patient says that they have falls in the first 1 or 2 years, a lot of falls. It's suspicious that it could be PSP. And PSP, as opposed to Parkinson's disease or Lewy body or MSA, is considered a tauopathy. So you see neurofibrillary tangle formation, which is what this slide shows, containing tau protein. The patients also have dementia. So here you can see the NINDS. The inclusion criteria is that gradually progressive, although overall I would say the progression is faster than Parkinson's disease, of course. The patients should have the vertical supranuclear ophthalmoplegia and prominent balance impairment with falls within 1 year of symptom onset. And the exclusion criteria are all the other features that we're going to discuss with the other atypical Parkinsonisms. So MSA is another, also used to be called Shy-Drager. Multiple system atrophy is a condition that comprises a combination of features of Parkinsonism, cerebellar ataxia, and autonomic dysfunction. So the most common presentation of MSA is a patient that presents with significant autonomic dysfunction and Parkinsonism. So it will often be a patient with severe orthostatic hypotension and Parkinsonism that start kind of in conjunction with one another. And so you carefully examine these patients, and you are also looking not only for the orthostasis and other features of autonomic dysfunction, which can include things such as urinary symptoms such as incontinence, urgency, frequency, a bowel movement problem, fecal constipation, or even incontinence, sweating abnormality, sexual dysfunction. We would ask about all of those. And on exam, the patients may also have signs of ataxia. So we will test them with finger to nose and heel to shin to look for presence of ataxia or incoordination of movement. We can also do rapid alternating movements, such as putting one hand on top of the other and flipping it quickly back and forth. And you can see the patient has clumsiness of movement. They may also have gait ataxia, where when they stand, the gait is very wide-based, the stance is wide-based, and the patient is unsteady. So multiple system atrophy, or MSA, is a synucleinopathy like Parkinson's disease. So you will see pathologically oligodendroglial cytoplasmic inclusions on pathology on these patients. And I want to mention briefly CBD. So cortical basal ganglion degeneration is probably rarer than the other two atypical Parkinsonism, but the clinical main feature is that it's a strikingly asymmetric akinetic rigid Parkinsonian syndrome. And typically there is one limb, typically an arm, but it could be a leg, which is very affected with a severe dystonia, meaning that the muscles are contracted, producing abnormal sustained posture. In the affected dystonic and rigid limb, there may be spontaneous myoclonus, or there may be what we call stimulus-sensitive myoclonus. When we take a pin, we can actually elicit, if we poke the limb with a pin, we can often elicit the myoclonus, but with a stimulus, such as a needle. The patient may even have alien limb phenomena in that limb where the arm may be doing something, but the patient will say that they're not initiating that movement. And cortical basal syndrome, so these features also seen in cortical basal syndrome, can be a sign in many other conditions. So here, these are the typical findings. They have Parkinsonism with this typically affected one limb. They have cognitive impairment and dementia. Cortical basal syndrome can be a feature of Alzheimer's disease. It can be a presentation clinically of Alzheimer's disease and other conditions. And here, so if it's not due to anything else, then we would call it cortical basal degeneration. And cortical basal degeneration is a tauopathy like PSP. And here I'm showing that hemispherically, even pathologically, you can see the left hemisphere is more atrophic than the right, and that's what you would see on pathology. Lewy body disease, mentioned briefly, it is the second most common degenerative dementia after Alzheimer's disease. In this situation, in this condition, we do see Lewy bodies widespread throughout the cortex and the brainstem. And typically, the patients will have a combination of Parkinsonism that is developing within 1 to 2 years of the dementia. So if the patient has Parkinson's for many years and they develop a dementia, let's say 10 to 15 years on, we will call Parkinson-related dementia PDD. But if the dementia and the Parkinsonism develop around the same time as one another in the beginning of illness, we call it Lewy body dementia. And a very characteristic feature is fluctuation of the symptoms. So the patient's family will often report that the patient may be very lucid at certain times of the day and other times much more clouded in the mentation. In addition, they have visual hallucinations. So that helps to differentiate from other forms of dementia, I would say, at the beginning. Typically, they're very well-formed hallucinations, and typically they're hallucinations of people or animals. And these patients can be very sensitive to antipsychotics as well. But unfortunately, sometimes we do have to treat with antipsychotics if the hallucination and psychosis is disabling. And I want to mention probably one of the most common conditions that we see in our clinic is drug-induced Parkinsonism. So here I want to show you, I'll just skip this for a second. So we know that drugs that block the dopamine receptor, typically blocking the D2 receptor is the worst culprit. Those are the old typical neuroleptics, such as haloperidol and fluphenazine, trifluoperazine. So you have second generation antipsychotics that have less D2 receptor blockade, but they still block dopamine, such as risperidone, olanzapine, Abilify. So we always review the medication list when we see patients with Parkinsonism to see whether or not they're on any of these culprits. The other drugs that are very important to realize may cause Parkinsonism are the anti-nausea drugs, compazine, metoclopramide, and Reglan, because these drugs, although they're just for nausea, they also block the dopamine receptors. And every year we see a couple of patients on anti-nausea drugs that have developed some Parkinsonism. So just something to be aware of. So the treatment for this, actually, drug-induced Parkinsonism should be fully reversible if you're able to stop the drug that is the offending agent. However, in many of these cases, it's really hard to switch them. So what we often will, because of the psychiatric illness. So we often will have a discussion with a psychiatrist and ask if they can switch to something with less dopamine receptor potency of blockade, such as quetiapine, which is actually quetiapine. We use it in our clinic actually for patients with Parkinson's with hallucinations because it has a low risk of Parkinsonism effect. Or nowadays also using Nuplazid, which is more of a serotonergic antipsychotic and is actually approved for Parkinson's disease, hallucination, and psychosis. And going back to this slide, this is a depiction of the basal ganglia with a bunch of holes, what looks like holes. They're actually lacunar infarcts. So we see patients who have stepwise deterioration of their gait. And what is happening is they're having small lacunar infarcts that are basically accumulating over time and affecting the bilateral basal ganglia. And we call this multi-infarct Parkinsonism. And we'll consider this a lower body Parkinsonism because these patients would not be expected to have a rest tremor, but they will have a progressive gait disorder where their gait will look like that of a Parkinson's disease patient with shuffling, short-stepped. So it's just something that one would consider working up for. You know, if you see a patient with a progressive history of multiple strokes and progressive gait, I would, do a scan to see if they do have a multiple lacunar infarcts, small strokes that may have caused that. Okay, UKPD brain bank criteria just require clinically that the patient has a combination of the cardinal feature of bradykinesia plus one of the other symptoms, rigidity, postural instability, and rest tremor. And the supportive criteria are the things we talked about. Exclusion criteria are the things that would cause atypical Parkinsonism. Oh, I forgot to mention also for MSA, you can have cortical spinal tract findings. So the patients, in addition to having a combination of Parkinsonism, autonomic dysfunction, and ataxia, they may also have spasticity and upgoing toes on exam and hyperreflexia. Okay, so it's important to differentiate idiopathic because we know that idiopathic Parkinson's does really well on L-DOPA. It's highly effective. And atypical Parkinsonism onset tends to be more symmetric. When you examine these patients, they tend to have bilateral sides affected pretty symmetrically. And unfortunately, they tend not to respond well to L-DOPA, but we still often do try levodopa, depending on, the situation. We often do try it if the patient has Parkinsonism. Sometimes it helps a little bit, so it usually does not hurt to try. And okay, so now we're going to talk about treatment. So still the gold standard treatment is Sinemet, and we have various forms of Sinemet. We have carbidopa, levodopa. That's the most effective gold standard treatment, even though it was discovered in the 1950s. And we have various formulations of Sinemet now. We have Rytary. Rytary is a combination of immediate release and extended release L-DOPA, theoretically used to treat patients after several years of being treated with Sinemet will develop what we call motor fluctuations. So the first 5 years or so, patients are smoothly controlled with their symptoms throughout the day. But after a few years of being on Sinemet, patients start to experience a shorter duration of good effect. We call that wearing off. And when the pills kick in, they have extra involuntary movements called dyskinesia. And we call all of these complications motor fluctuations. So Rytary was developed to treat the motor fluctuation by giving a combination of immediate and extended release Sinemet. And now we also have Crexont. We're going to talk about Crexont, but essentially it is even a newer generation in a way similar to Rytary. So we also have all these class of drugs, dopamine agonists, which stimulate the dopamine receptor to produce more dopamine. Those would include ropinirole, pramipexole, and rotigotine patch, and apomorphine. Apomorphine is an injectable, which would give the patient a quick on state. Dopamine agonists, unfortunately, do have a lot of side effects, so they wouldn't be great. They certainly wouldn't be recommended drugs, I would say, for elderly patients because of the side effects of hypotension, hallucinations, impulsivity, and rarely falling asleep while driving. So those would probably not be good drugs for elderly patients. And I usually avoid using those for patients above 70. We do use methyltransferase inhibitors. These are drugs that inhibit the breakdown of dopamine. So essentially extend the half-life of Sinemet. So that can be used as an adjunct to L-DOPA. And MAOB inhibitors are another mild symptomatic therapy for Parkinson's. You can also use anticholinergics, but again, anticholinergics may have a role for some patients with a lot of tremor. Some patients respond really well to anticholinergics for tremor, but I would not recommend that for an older population because you know all the side effects: confusion, urinary retention, dizziness. So not recommended for elderly. Now, actually, I want to talk very briefly about these new drugs that have been developed. We talked about pimavanserin, it's Nuplazid. It's a drug which is FDA approved for Parkinson hallucinations. So I guess that tells you in a way how frequently we do develop hallucinations on the L-DOPA, such that a drug is developed for this. But the advantage of that is more of a serotonergic drug, so may not have as much risk of Parkinsonism, but it still has some because it still does block dopamine receptor to some extent. We have an inhalable form of L-DOPA. Then on this list, I would say the more significant things have been Crexont. Crexont is a combination of immediate release and extended release Cinemet. So it's good for motor fluctuation. We also have these levodopa subcutaneous pumps. So before the subcutaneous pump, we had Duopa. Duopa is an intraintestinal delivery of levodopa where a PEG J tube is implanted and the patient can get the liquid L-DOPA pumped through their intestine with the pump. But unfortunately, a lot of patients don't like, the idea of having to implant a PEG J tube to get a continuous L-DOPA. So now on this side, you see Vyalev is a subcutaneous levodopa pump. The patient is similar. Many of my patients told me it's similar to an insulin pump. The patient just installs the needle into their subcutaneous fat and through the pump gets continuous L-DOPA delivery. And more recently, Onapgo pump, which is apomorphine, has also come out. So those are two pumps that one could offer for patients who have motor fluctuation. I want to mention briefly subthalamic deep brain stimulation. So I wouldn't say that all patients subthalamic DBS and actually another target is GPI. It's a highly effective treatment for motor fluctuations. It is a brain surgery. There is implantation of electrodes in the brain, and they are connected to a battery which is placed in the chest, which delivers the electrical impulses to the brain to control Parkinson's. It's extremely good for tremor. For patients who do not have good response to medication of tremor, they will have good control with deep brain stimulation. The patients that are good candidates here, I wrote 40 to 70, but I really should nix that because we have had patients 80 and above who have undergone DBS for Parkinson's with very good response. The key is that the patient has to be appropriate for surgery, meaning they have to be cognitively intact. Patients are all screened for that with neuropsychological testing, and they have to have bothersome motor fluctuations. The advantage of DBS is that once the electrical stimulation is controlling their symptoms, we often can reduce medication significantly. Sometimes we can cut the L-DOPA and all their medication by 50% or even 70%. And we have 20-year data that the DBS continues to work. Of course, there is also risk with surgery. So risks are 1% to 2% risk of hemorrhage and a higher incidence of possible infection. But for the most part, it works really well. Patients also do have to come in for ongoing programming. Once they have the implantation, they come back to see us to get programming, meaning that we adjust the stimulation to help that patient's symptoms. And studies have shown very good long-term response of the surgery. Now, the more recent thing is that in 2016, Focus Ultrasound was approved for essential tremor, which is basically a benign age-related tremor, which occurs mainly with action and holding a posture. In 2018, it was approved for Parkinson's tremor. At that time, it was all approved unilaterally. Focus Ultrasound involves focusing an ultrasound beam to essentially lesion the brain. The target varies, but generally it was the thalamus. The thalamus is a center for tremor. So a focused ultrasound lesion of the thalamus was created using the ultrasound machine. And it's very good for tremor control. So the advantage of this is that nothing is implanted in the brain. So the patients, once they have the surgery, that's it, and they're done. And now it has been approved most recently for bilateral, but it has to be staged. It wouldn't be done both at the same time. the patient would get the right side, for example, and then come back maybe a month or two later to do the second side, the other side, for Parkinson's. The disadvantages are that there is potentially some transient ataxia that may occur after the surgery. And of course, you could get anything that you might get with lesioning. However, overall, it seems pretty safe and very well tolerated. I have had patients go for the surgery for essential tremor at over 90 years old and pretty happy with the results. I don't think I'm going to have time to discuss this, so maybe I'll just move on to my videos. Okay, let's show this video. I'm just going to show each. Uh-oh. The video's not running. Oh, I wonder if I have to show it from my slides. Oh, there it goes. Okay, thank you. Okay, so I'm just going to show briefly. You know, when you look at this guy, at first you think the video's not running, right? The movement is so akinetic, but eventually you do see this guy he was 90. And so he came in because he had just developed this tremor that he noticed, and it was primarily right-sided. And so this is an example of rest tremor, okay? Here you can see that overall his right hand is more affected than his left. Okay, and then we see holding a posture, there's no tremor. So he has a pure rest tremor. Yeah, and actually you see here, we test action tremor. He has no action tremor either. Otherwise, he would have a tremor when he tries to touch my finger. And this is a good position in which to look at tremor, look at the presence of postural tremor. We always test rapid movement. So we're testing now finger taps, and we look to see if there is not only slowing, but what we are looking for is a progressive decrement of the movement over time. So initially, they may be able to initiate a pretty rapid movement, but over time, you'll see there's a reduction in amplitude and velocity of the movement. And he does have that on the right hand more than left. Okay. Okay. And then here, actually, he gets up really well from a chair. That's another thing we look at. Many patients have problems getting up from a sofa. Walking is actually quite good. Here, you can see that he walks fairly well. He does have a little bit of the stoop posture. Okay, let's move on to the next slide. So this is okay, let's run this one. This one is a quick one. So here, this is Joan, one of our nurse practitioners, and she does programming for the DBS. Now, this DBS programmer is very outdated. We now have a wireless. Okay, this is from 20 years ago, but no, 15 years ago. But as she goes up on the voltage, look at the left hand. So at 3 volts, the tremor is interrupted, and he's very happy. So that's what she's doing there. Okay, we'll move on to the next slide. Now, we didn't talk about essential tremor, but essentially essential tremor is a benign, well, it's considered a benign age-related tremor where the patient has primarily tremor with holding up posture and with action. Now here, if you look at this guy, he does not have rest tremor. And holding a posture, there is a slight tremor in the right hand, okay? And we don't know exactly what causes essential tremor, but we do think it has something to do with the cerebellum and the cerebellothalamic tracts. So here you can see his tremor is really pronounced as he reaches the target there. That's an action tremor. So he has essential tremor. So for essential tremor, the treatments of choice are usually primidone or propranolol, and we may pick which drug based on the patient's other medical illnesses. This is another condition which is also approved for deep brain stimulation and focused ultrasound. There are some patients that don't respond to any medication for tremor, and the tremor is very disabling. Although I say it's benign, it can be quite disabling. If it's like this fellow's tremor, he cannot even really hold a cup with one hand because the hand shakes so much. Okay, let's move on to the next video. I want to show you briefly this lady. This is a lady with progressive supranuclear palsy. And here you can see she has a very typical, very masked faces. They have like We say that the face looks very startled, but it's really dystonia, dystonic facies. So here, pretty soon I'm going to be testing her vision. Oh, I don't know if anybody can hear anything. It's okay. So. Yeah, sorry, I don't think the sound is working, but it's okay. So here I'm looking on the right, looking upwards. I'm asking her to look all the way up. Her eye movement is impaired. She cannot fully get her eyes all the way up. She is trying. The eyes move a little bit, but the saccada, the eye movement is impaired. And so we would not expect that in Parkinson's disease. And down is also, now she's looking down. So that's a typical thing. So unfortunately, the patients with PSP and the other atypical Parkinsonism progression tends to be more rapid. Some of the patients will end up wheelchair dependent within about 5 years. But we have seen patients probably with PSP over 10 years. Okay, so that's that. And we'll move on. And I want to show you briefly this patient. This is a patient that came in with a problem using his right arm. He noticed that he was having difficulty using tools and doing things with the right arm. The left arm was relatively better with being able to do daily activities. And it's not very apparent in this video, but I was trying to test for what we call cortical sensory findings, where we write a number in the hand to see if they can identify the number. And he wasn't able to do it with the right hand. He was better able to do it with the left hand. So, and here, I think you can see when I let go of the hand that the hand is in a funny posture. The fingers are flexed and dystonic. So he has likely cortical, and here you can see some of the tremor. It's almost myoclonic. He has cortical basal degeneration. Okay, well, thank you so much. Very happy to talk to you about all the work we do in the Movement Center. So I don't know if there are any questions.
Thank you so much, Dr. C, for this fabulous talk and for keeping us so up to date with Parkinson's. Unfortunately, we don't have time for questions, but we'll send you a couple after the fact that we'll share with our audience. And we really, really appreciate you coming to speak with us today.
Oh, thank you. Thank you so much. All right. Take care.